Okay, now I call upon Dr. SUMA Ganesh, my dear friend, the Director of Academics in Shroff Eye Hospital, to talk on what is new in amblyopia. Over to Dr. SUMA.
Respected chairpersons and my dear friends, I would be speaking on updated amblyopia. After all these stalwarts speaking and with so many publications, I am really feeling it's because I don't have a publication in amblyopia. But it's a treat to watch all of them. So I'll be just going to the what practical approaches we have in treating with amblyopia. Means over the years. So all of us are aware of the definition, but I think all cases we have to see that whether there's a unilateral or a bilateral decrease of visual acuity, which is basically caused by a deprivation of pattern vision or abnormal binocular interaction, for which no cause can be detected by physical examination of the eye, and which in some cases can be reversed by therapeutic measures. This is what exactly the definition of amblyopia is. And it could be strabismic, stimulation deprivation amblyopia, anisometropic amblyopia, meridional ametropic and combined strabismic and anisometropic. So we have all, from the last so many years, we have worked our practice on PEDIG because most of us have been along the PEDIG studies. And how well do glasses alone treat amblyopia is one question. Do we really know that patching works? How many daily hours of prescribed patching are necessary? What happens when patching is stopped? Does atropine work as well as patching? How often does atropine need to be used, and does patching work in older children? So these are the few of the questions which in practice we all want to know. Yes, refractive correction, I've seen in myself that please do not start patching therapy before refractive adaptation. Give them time, 2 months when you're giving the glasses. Let them wear the glasses for 2 months and we review them after 2 months. And then we see that most of the time the children do improve. So there is, if patching is needed, then we need to do patching only after 2 months. So we wait till 2 months before starting the patching. So now when do we give glasses? Now all of us talk of amblyopia and patching therapy, but it is not an easy thing to do, the patching therapy in children. All of us doing pediatric practice knows that how difficult it is to even patch, and the amount of torture and the trauma the parents and the children suffer. So can we prevent amblyopia? Something we should all work on. When we see babies, please don't say we can't do the vision, we can't do the refraction. I think we all should have in our clinical practice enough tools to do the refraction, to do the vision assessment. So we should know the guidelines. So this was in a consensus where we all attended, and Dr. Santan Gopal is here, and Dr. Rohit and Dr. Pradeep Sharma, sir is not here, but we all met. There was a group of 33 pediatric ophthalmologists, and on that occasion in 2020, we published the guidelines for amblyopia therapy. So it is slightly different from the American guidelines. So it is myopia if less than 1 year, and if you get the refraction of more than -3, we need to prescribe glasses, and 1 to 2 years more than -3. So this is something we should remember, that we should prescribe glasses in these children. Don't say that the child is too small and we can't make the child wear glasses. Hyperopia more than +4. Hyperopia with esotropia, we put it as 1.5. Though American guidelines say 2, we have come with the consensus that we should prescribe in more than 1.5. Astigmatism more than 3, and more than 2 when the child is 1 to 2 years. So this is how we will, in a pre-verbal child, we will give glasses and prevent amblyopia, so at least they don't have to do patching later. What is an anisometropia more than 3? Hyperopia even 1. I would say here we are put as 2 and 1.5. But I would say that even if you find a difference of more than 1 diopter, we should prescribe glasses. Oblique astigmatism, if you get, even if it is 0.75, we should prescribe the glasses to prevent amblyopia. So what is the diagnostic criteria? Is of course asymmetric resentment points towards poor fixation in contralateral eye. The fixation preference we have to see, and preferential looking chart. So now we have the TAC. Of course these are expensive, but maybe we could use the LIA symbols, which are not very expensive, and use them to do the vision assessment in these small children. And so the best corrected visual acuity we should test on optotypes. Of course these are for more than 3 years of children. So then when we get to do the occlusion therapy, which is most of the time which the children present, patching is still the gold standard. Please do not go to dichoptic exercises and to other treatment before starting patching. because I still believe that patching is the only, because we have done a lot of software programs without patching, and we have found that it is maybe when the child has already done patching and you want to start it, it's good, but it is not the primary goal of treatment. For a severe amblyopia, it is preferable still to go for a full-time patching, especially when you have to do, if there is a strabismic amblyopia, esotropia, and I want to operate early. It is better to do a full-time patching and get the vision improved, and then go ahead for the surgery after you find there's a 2 or 3 line improvement. So, and for a moderate amblyopia, you can do up to 6 to 8 hours patching, or we can even do 2 hours of patching with intensive near work. So is there any alternative? Parents are always, children are not willing, parents are crying, and there's a lot of social distress. So penalization, I've used it rarely, but most of the time what happens is that it's in severe amblyopia, and I do not find the normal eye vision being, even if you penalize the eye, still the normal eye vision is still better. So, it means it doesn't work, and then only I think it works in moderate amblyopia. In severe amblyopia, we tried. The vision is still better in the normal eye, so it does not work well for severe amblyopia. Pharmacological agents, ceticoline and carbidopa. So this was a nice paper. In fact, we had a nice webinar with Prachi, and she said that she had published a paper in 2014 and worked on the effectiveness of addition of ceticoline to patching in the treatment of amblyopia around visual maturity. So it was a randomized controlled trial where she took one group where she had only patching and the other group with the ceticoline. And they found very good results. Not in the first 5 months, that's what she said. You have to wait for 5 months before the effect comes of the treatment. So you have to wait, give the treatment. So in the first 5 months, you do not see any improvement between maybe the patching group, you'll get a better improvement. But after 5 months, she found that, and up to 12 months, there were significant differences in the visual acuities in these two groups at the respective intervals. So ceticoline is an option. Liquid crystal glass it was in between, it had come up, and I remember we had used it in 2-3 children. But I think it was more, it didn't cosmetically acceptable, but I didn't think it proved its value, because few parents took it and then I think it was not working. So then there was no proven studies also on the long-term outcomes. So the new modalities are the dichoptic exercises, because now what to do? So the video games, there are 3 approaches to improve visual acuity. You play the video game with a non-amblyopic eye patched in order to improve aspects relating to crowding. The second method uses it as an anti-suppression strategy, where the same background is presented to both eyes, but an enriched foreground is presented to the amblyopic eye. And the third strategy is to play a video game specifically designed to develop stereopsis. So there's no financial interest, but this is what we had used, so I'm presenting it. So INET amblyopia program, this was what we used. We used the principle of operant conditioning and behavior modification. And in this, patients we need a vision more than 660, otherwise this doesn't work. 660 to 636, the targets are there, they can be easily seen. And they become progressively smaller as therapy progresses. Oh, so fast. So we did the evaluation of this, and we found it was effective. We did a study with 63 children, and we did one group with only INET and one group with INET and patching. And we found that it improved, all the lines improved in all the different types of amblyopia. So there was significant improvement in visual acuity by using the INET exercises. But this again was monocular actually. So then we started the dichoptic therapy. And the dichoptic advantages are it is useful for adult amblyopia, faster effects and better compliance. We use the Binox also, and the Binox is, we did a study with Binox also, and to see what are the effects of Binox software program. It was effective, but we found that in strabismic amblyopia, you need to have the eye ortho. So you need to give in very high degrees of strabismus, we could not give the Binox therapy. So if we could give prisms in the glasses, if a small amount of ESO or EXO, and then do the therapy, it was found to be effective. Now Revital Vision is the new modality, and they seem to be working on the perceptual learning therapy program. And they have found good results. I have not used it personally, but I have been I have met and with Dr. I think Savleen is using it in PGI, and Dr. Sumita is using it in Shankar Netralaya, and they have found the studies itself say that they have got good results. We are going to try it now because there is also an improvement in the contrast sensitivity, and they feel that the vision has drastically improved. Of course, we have our own star, Dr. Sandan Gopal, who has looked. He has published a paper in IGO on looking beyond occlusion, a novel perspective for amblyopia treatment. It focuses on visual attention and it's an orthoptic magnocellular stimulator. I've seen few results and they are very promising. It improves the stereopsis, visual acuity and hand-eye coordination irrespective of ages. Thank you.
Thank you, Dr. Suma, for that wonderful talk. A very difficult topic, yet still we don't know about the prospects of treatment with as new modalities like orthotech are coming up. I think there is a lot more area to try, especially in adults. That is the age when they come. 20 years, 22 years, they come and say, we are recruited for something, but some job, but amblyopia therapy has a lot of potential in this age group. So, wonderful talk. So, let's go to the next topic.
I would just like to highlight one thing in Suma's talk. That's okay, you be there. That the 4 to 6 hours of patching, actually 4 hours of patching has been recommended by PEDIG ATS studies. That is for moderate amblyopia. And as you rightly said, when the amblyopia is severe, then we have to resort to full-time occlusion with all its practical disadvantages. And very often it is a good idea to use the school vacation time to do this. Otherwise, the parents are not very willing to accept full-time occlusion, which is the only answer for severe amblyopia.
I would just like to know anybody who's using Binox. We have done a few cases, but not very much convinced to proceed further. Sir?
It works well in situations where patching works well.
Yeah, I think Dr. Varimbe has a
Yes,
paper.
but if you have problems with patching, yes, Binox is a good alternative.
So the results in anisometropic and ametropic amblyopia are good. And interestingly, the stereopsis has also improved. But you know, whenever any new treatment comes, there are always two theories. One is always, you always go behind it, it's a novel treatment, it's the gold standard. And on the other side, you just shun it away, it's not going to work. So I think as a scientific community, we should evaluate, it should stand the test of time. And I think we should evaluate on the robust statistical methods. So for 4 months, the results were statistically significant, only in these two categories. And I think it would be interesting when I see the results of these 275 patients. So the next year, I think I should be able to tell you. Right now, I don't know.
Thank you. That's a good number. I think we have to be very selective in choosing the patients.
Dr. Parikshit helped me in evaluating all these results. So
think
thanks
so
to
the
him.
All your patients, sir.
In the interest of patient, I think we will